Yeah, thank you for giving me the opportunity to share with you some of our thoughts on the role of 3D printing in orthopedic trauma. 3D printing in form of 3D models for patients, for teaching, for pre-visualization has been long around. It's nice to have a haptic contact to see the fracture, but this is more or less nice to have and doesn't have real impact on patient outcome. But I would like to share with you 4 examples that this is going much more further. We can use 3D printing as a diagnostic tool, for example, for forearm deformities and analyze the collisions. Bone joint defects can be substituted in articular or long bone segmental defects, and it helps as some sort of navigation, 3D printed tool navigation, in order to achieve reduction and achieve certain targets during the treatment process. I'd like to start with this model of a young gentleman with a forearm fracture, ulnar fracture, a radial fracture, malunited, and he has a significantly impaired forearm rotation, and the 3D analysis and the 3D printed models help us not only to analyze the deformity, but also find out the location and the placements for the corrective osteotomy in order to achieve union. So we just mirror and copy the healthy side, which is in gray, to the ipsilateral deformed side, and we can now clearly identify the problems. The impact during the forearm rotation, that the distal radio ulnar joint is completely displaced during the end pronation, and it also helps us to identify the location and to define the new axis and the place for fixation in order to overcome this. And this is done on the computer, but we can then print it out and also test it mechanically as a physical model. This is pretty basic, but the next step is even is somehow more advanced. That's a gentleman who was falling 8 meters through a roof and had an femoral fracture and a open defect fracture of the distal humerus. The large central piece of the trochlea was missing. We still have left the ulnar side a piece, and we had still a little piece of the capitulum and the clip, the slip for the radial collateral ligament, but the large central part is missing. So what are the therapeutic options in such a patient? They are quite limited. The elbow arthrodesis, elbow joint, etc., etc. But there are many parts of the joint which are still in good shape, so we were planning to a customized segmental model for the defect. And the nice thing in 3D printing is that you connect it with other tools like this little plate element in order to fix it to the distal shaft of the humerus. We also had a roughened surface and titanium surface in order to allow bone ingrowth. We had in the distal part, we have holes for the fixation of the capitulum in order to make this a sound construct. Again, here's a postoperative film. The radial capitulum is a little bit flaw in the X-ray, and patient was healing uneventful. Here his function after about 1 year, nice forearm rotation, his flexion of the forearm, however, is a little bit limited. He comes to 80-degree and also has an extension gap, but still, I assume, better compared to all other potential options. We can use 3D prints as some sort of navigation. We can use them as a reduction tool. And this was the case in this polytraumatized example: massive liver trauma, chest injury, femoral shaft fracture. He got DCO and packing, but he was bleeding so massively in the chest, so he needed a lung resection in order to stop the bleeding. Later got some lung transplant on the right side because of his decreased function. He was for weeks on ECMO and ICU, so no way to bring him down to theater for femoral nailing, and we had the external fixator in place. So here comes in role a so-called reduction external fixator, which is based on the CT model of the healthy side compared to the fractured side, and it analyzes the deformity. And the 3D print is made that it fits to the existing shunt screw in place, and once the middle segment is snapping into the proximal and snapping into the distal fragment, it is the fracture gets reduced. This went nicely in this and several other cases. We see the patient on the right side, and he has this reduction external fixator on his femur attached, this white device. And here's the postoperative CT scan showing a torsion difference of 4.1 degree. The gray 3D model is the previous unreduced or limited reduced fracture situation, while the blue one, the post-reduction with the reduction external fixator is. So also a nice option to do a femoral reduction with high precision in the infrastructure of an intensive care unit, where you do not have image intensification, where you don't want to open a fracture. So this is also a nice option, which is available due to the possibilities of 3D printing. Here's a chest X-ray with a new lung. Looks almost like a normal lung. It's really amazing what this lung transplant can make. What a difference. On the left side, the long-standing films, nicely brought out to length, no torsional difference, and sound fracture healing on its way. In a final case, they use again as a 3D navigator in Mohammed, a 24-year-old patient with a B-type femoral fracture, which was malreduced in Libya. Had significant varus, had significant pain, VAS 6 to 8, and presents 2 years after trauma. And when we see the plain film and the arthro CT, we see the significant deformity, we see the significant bumps, but the closer analysis is visible when we see the superimposed mirror healthy side, gray, and the injured side, we see there is a significant gap in length. The medial condyle is too short, and it's also deflected. So a multiple deformities in one condyle. So again, 3D analysis using 3D data, and this is nice on the computer. You can play very much different levels of osteotomies, and once you defined for the perfect cut for the osteotomy, so you also can plan for different connectors which are necessary in order to attach oscillating saws or other devices. We use the existing drill holes, which is easy because they are clearly defined in the 3D data set. And with these informations, we printed several blocks, several master blocks to the distal and proximal fragment, and they all have snap-in connectors. So once they are connected, they give a predefined orientation. You look on these 3 images, how nicely they fit to the very individual anatomy. There's some sort of a snap clamp into a very irregular bone, and it's fixed with the existing screw holes. Here's a proximal master block, which can be then connected to different cutting blocks. And here's the osteotomy blade. And this is the situation after the osteotomy. And this is all done without much of a soft tissue dissection in order to orient no soft tissue dissection of the supracondylar pouch area. This is all very possible with minimal amount of dissection. Alignment check, final alignment check, and they also did some cartilage transplant for the defects, and that's the situation with the post-op imaging. We see a very nice straight leg axis on the revised distal femur. We see the bumps have gone, and we see also that we have quite a good achievement comparing the gray fractured side as a gray healthy side with the green fracture side. So we see condyles, the medial condyle came out to length, and this is addressed quite nicely on the imaging. But at the end, what counts is function, and the function also has increased significantly. The Lissome score went up to 80 out of 100, and the pain significantly reduced from 5 of 10 down to 0 of 10. So 3D printing can do quite a lot. We gain a lot of new reconstructive options, and patient specificity is something which we also see in other disciplines, like they do tumor therapies very specific on a specific patients. So this is also the case in orthopedics and in musculoskeletal therapy. Diagnostic substitution it can help. 3D printing can help for better diagnosis, it enables us to substitute missing bone, and it helps us in some sort of navigation with increased precision, less invasivity. But still, there are some costs related to it, and potential medical legal aspects, standardization, quality assurance, and also this is something which needs to be taught to our next generation of orthopedic surgeons. Thank you very much for your attention.